Hi, everybody. Welcome to Waking Giants EDU, your anxiety antidote and end-of-life conversation with Rabbi Lev Beish. Thank you so much for being patient. My computer decided it wanted to take a break at a very inopportune time. But just some housekeeping rules. You're more than welcome to donate to the rabbi. You are more than welcome to donate to Waking Giants. I'm going to include some links for you to be able to do that. If this brings you peace and quells your anxiety, or some of our other programming has most definitely helped, I will also include a link with our scheduled events. So this presentation is going to have some slides and some other information. If you would like a copy of what you see here, if you could please chat me, Rabbi Beish, or if you feel comfortable enough in the public chat window, your email address, and we will most definitely email those items to you. Side note, everyone should be muted but myself and the speaker. You do have the ability to take yourself off mute if the speaker prompts you for questions. Otherwise, please do us a favor and keep your mic on mute because it helps with the video quality and the audio feed. Another thing is this session is recording. So if you have your video visualized and we can see you and you can see us, well, you can't see me, you see I, then don't get up, because if you're not wearing pants, we will know and it will be saved and the internet keeps everything forever. So with that being said, again, if you'd like to donate, those links will be provided, and get on our email list or get an email with all of these documents. That'll all be in the chat window. Oh, one more thing. The chat window, the chat function's great. It's wonderful. It's a great way to engage with the speaker. And also, if you want to ask questions anonymously, you can chat myself directly. You also are able to raise your hand. That's another great function if you would like to speak or have a question. Otherwise, let's get going.
Hey gang, it's really lovely seeing some people and also just seeing some names there too. Nobody has to make themselves known here. I want to present in the most respectful way. I also, Roz said something about making donations to the rabbi, so nobody's going to be donating to the rabbi. I'm doing this as a gift from Hospice Austin, from the St. David's Foundation, Hospital Foundation, and also from Waking Giants. So any donations that you make go to the organization, but they don't come to me. I'm not expecting anything, and I would turn them over anyway. I wanted to tell you a little bit about me for those who don't know me well. First of all, I am a certified hospice and palliative care nurse, and I work with Hospice Austin. I've done home hospice and Christopher House, our hospice house in Austin. I've also worked as a nurse for the Texas Hospital Association in all of the rural hospitals in West Texas, and I did some patient safety and quality management there. And I started at Brackenridge Hospital, which is our county hospital in Austin, and I worked in the orthopedic, neurology, and plastics department, helping patients after they came in from surgery, from trauma, or from trauma that brought them directly to the emergency department. So, and the reason that I started teaching in the community around end-of-life planning had something to do with the fact that at the hospital, one of the things we noticed was that people were coming in and they had never spoken to their families about what their wishes were at the end of life. And when it came time for them to talk about it, it was a very difficult situation because we were doing it not as end-of-life planning, but as emergency planning. We were having the conversations as patients were being put on hospice care, or even just before they passed away, before they died in hospice care. When we were trying to settle people into our organization, into hospice care, and they hadn't had these conversations yet, the first thing that we had to do before we could really hook them up with our services, beyond making them comfortable, was to talk to them about what their wishes were at the end of life, and had they communicated that to the people that they love, um, and and could we be of service in facilitating that. For the patients who had had the conversations much earlier, their end of life process seemed to be much better, because people were aware of and appreciative of what it was people were looking for in their end of life experience, and not trying to figure it all out on top of all of the kinds of things that people need medically at the end of life. So Hospice Austin got a gift from the St. David's Foundation to do this conversation in the community. We would go into hospitals, work with nurses, doctors, nurse practitioners, social workers. I've been doing these trainings with our EMS, emergency medical service providers in the community in their training program. We go to churches and synagogues, and we've worked with mosques, communities. We've worked with people in wealthy communities and in impoverished communities. And we try to bring this to everybody so that the conversation is one that the whole community gets to be a part of, and it's not just focused on a particular subset. And now, because we're cloistered at home, this is an opportunity to try it in a different venue, and that is to do it online. So thank you for coming and for being a part of this, and for being willing to participate as much as you choose to. For the beginning, I'm going to just give you some information, so we don't need to have a lot of conversation, but in a little while I'll open it up and we'll do some hand raising, and you can ask questions. And also, if you're chatting with Roz, she'll be able to share some of that with me without sharing your name, so I can answer some questions that you might have. So first, I wanted to say that this feels like a really different time in terms of having conversations about end-of-life planning than sort of normal life, when we're not under restrictions by a virus that's traveling around the world very quickly. But in some ways, it's exactly the same as those times, because when people are in the process of dying, when they are rushed to the emergency department for a heart attack, or they have a cancer diagnosis that has finally progressed to a place where they're needing emergency care, it's the same or experience as somebody who's having trouble breathing and is picked up by an ambulance and taken to the hospital now, and is suffering through that. I think some of what makes it different right now, clearly, is that while there are some treatments for all of the other possible ways that we could end up in the hospital, like heart attacks, and there are medications and there are surgeries, and while cancer has chemotherapy and radiation and all sorts of alternative medical treatments, COVID-19, we don't have that yet. And so I think the fear factor and the anxiety factor around this are much higher right now. My whole purpose tonight is really just to give you some of the basics about why it might be valuable to have this conversation with the people you love, even though it's going to be different from being able to do it in their living room or around a dining room table. And it's not going to be at the time of the year that you want to have it. It may be right now, and this may not be that time for you. But give you some ideas about why it's important to do that, and how to have the conversation, to ask you questions about what kinds of things get in the way of people having this conversation about end of life, who people need to talk to. And also I have some screens I'm going to share with you, some of the documents that people get in preparation for end of life planning, the out of hospital do not resuscitate order. And that's the order that is signed by witnesses and by a doctor that says, if I'm at home or anywhere except in the hospital, and I choose not to have my heart started if it stops. Um, this is the form that needs to be filled out to make sure that EMS does not try to perform CPR and does not try to restart someone's heart. There's that form. There's also the one that's called medical power of attorney. And that's when you assign the rights to make decisions about your medical care in an emergency situation when you are unable to speak for yourself. And I'll talk about the parameters around what it means to not be able to speak for oneself. It's also important to remember that this a medical power of attorney only speaks for you when you can't speak for yourself or you don't want to speak for yourself. They don't take over if you're talking and you want to be in charge of your own medical care. They're there really as an appointed person that you appoint to speak for you when you can't speak. The third document is a living will, and it's also called an advance directive to surrogates and to physicians. And that's the one where you get to tell the medical team ahead of time, and it may be as soon as you hand them the document when you are wheeled into the emergency department, but it's, or you give it to EMS as they pick somebody up in the world. And it says basically, I've made a choice, two different options. One is if what's happening to me is life-threatening and I am not going to survive this, please either do everything you can to sustain my life as long as possible, or do everything you can to make me comfortable. The second one is if I'm going to die immediately, but if I'm going to be in an altered state that's going to require long-term care and I'm no longer going to be able to participate in the world. I might have be in a coma or have had a stroke or be able to communicate in an effective way. Either do everything you can to sustain my life or do everything you can to make me comfortable, but not life-sustaining. And I want to be very clear that the options are not do everything or do nothing. It's do everything for life sustaining or do everything for comfort. And comfort care may include oxygen, medications, um, uh, keeping me clean, doing all of the things to care for me. It may include feeding, but it's not about life sustaining at that point. Uh, I want to first start with the conversation itself, and then we'll get into the documents later. Let's see. I just wanted to see if anybody had anything yet. No, we're good. And it's really beautiful to see that there are people from all over the country here so far, and people I know and some people that I haven't met yet. And also, by the way, along with being a hospice nurse, I'm also a rabbi and I'm an attorney. Some people say that I come in as a full service hospice staff member because I can execute documents, give you your medications, and also present you with whatever healing blessings you would like at the end of life. But here I'm going to be here as a nurse. So a couple of things. One is, why is it that people don't want to have the conversation about what are my wishes at the end of life? Some of it has to do with not wanting to be a downer, not wanting to bring everybody's attention to death, but really to kind of stay focused on where we are and how healthy we are and that everything's going to be okay. There's something that I think sometimes people are afraid if they talk about end-of-life care and their end-of-life wishes, that hope will disappear. And I think hope is one of the things that we're looking for most in the world, especially right now, when we don't have a lot of information about where we're headed. We rely on hope, I think, in this place. Some people feel that they live in a world of magical thinking. I remember for those who are my age-ish, there was a movie, 16 Candles, and some of you may have seen it as a later release for a second or a fifth time. In the movie, the family's sitting around the table, and somebody has cancer. And so they want to talk about that person. And whenever the word cancer comes up, they say, and they just whisper it. And there's a fear that if you say the word out loud, somebody's going to catch it. And I think that right now, especially when we're so afraid that this virus, which is easily spread through the community, is so easily brought to us, that if we talk about it, if we talk about end of life, that maybe the virus was going to catch me even easier. Um, and I do understand when people have that kind of magical thinking. I don't. It's not a judgment about it. It's just some of the kinds of thinking that we walk around with. I'm sure that everybody, including me, we all have some magical thinking about if I say or do a certain thing, I'm going to bring about a certain action or a certain result, and it's magical no matter what it is, whether it's life-threatening or not. Some of us don't want to bring it up because we think that there's a perfect time to talk about end of life. And one of the things that we say in hospice is that it's always too early until it's too late. And we want people to understand that if you only wait until the diagnosis gets so serious, or someone's on their way to the hospital, or they've already arrived there and they're about to be intubated, if they're going to be forced a breathing tube to help them breathe, and they're not going to be awake or speak during that time, we've gotten to a place where this is no longer advanced care planning, and people are going to be making decisions in crisis moment. Um, uh, Also, sometimes people are worried that the people they're speaking to don't want to talk about it. They don't want to hear about it. They don't want to think about it for themselves. And that if I bring it up for myself, that I might be bringing up something in you that you don't want to talk about. Um, and we do that a lot with other people. We kind of prejudge how they're going to hear us and what our words are going to do to them. And so we stop ourselves from doing and saying important things. There are also those families, and I am part of a larger family where there is some of this, and that is where there are families who don't talk about things like this. We just don't talk about it. We talk about the food and we talk about the weather, but we don't go into the deep, heavy stuff. And I do understand that as well. Those families need this as much as everybody else, and so I think there's a way that we can broach this conversation so that, and I'll give you some of those ideas, when it's not the kind of thing that people in your life usually do. Also, there's the big one, which is I don't want to worry anyone. If I bring up that I want to talk about end of life ideas, people might think, oh, does he have the virus and he's not telling us? Or, oh, is his heart not working well? Something going on. And did the cancer progress and we're just finding out this way? Um, and so it's really important, I think, to be aware that that's the worry that we carry, and we need to be aware of it if we're going to have this conversation. Some people think we're just too young. This is what old people talk about. Our grandparents talk about it, or great-grandparents talk about it, because they need to. But here's the truth. When we work in the medical world, when somebody comes in who's 97 and they're actively dying, it's sad, and it is something we want to make as comfortable and as easy and as engaged for the people who came with them as possible. But it's also expected. It's something that we come into this world knowing that if we live that long, that something is likely to happen to us. But really, it's the 60-year-olds and the 40-year-olds and the 20-year-olds and the teenagers and the little kids. It's when it's their time and they're at the hospital and the family is standing around and nobody's discussed this, that's when it becomes really difficult to work with people. It becomes difficult for the family to support each other. It becomes difficult for the patient to get the support from the family because they're all struggling with decision making at that time. And it's difficult for the medical staff because we want to provide the best care we can, but we don't know what it is that the person or the group wants to make happen. So the more that we can talk about that early, the more we can offer when the time comes. Um, who are the people that we need to talk with? We need to talk with our family members, the ones who it's easy to talk with, the special brother or sister, the cousin who we share everything with. Maybe it's mom, uh, maybe it's dad, maybe it's somebody there, and maybe the rest of them we don't always share deep stuff with. It's important to talk with them too. If we only tell the people who are the closest and the easiest, when the time comes to need this conversation, it's going to be much harder to engage the rest. And also, there might be some sabotage in what's going on around a hospital bed when people are trying to figure out what this person wanted if they only shared with a couple of close people. It's important to tell our friends also, because the larger the circle of support is, the more that people can take care of us and themselves and each other. When we think about what happens when someone is mourning the loss of their spouse or their child or their parent, and they're mourning the potential loss, it's in the moment, it hasn't happened yet. The other people need to be around to know how to take care of that person so they can take care of the person who's dying. And so the more people we tell, the bigger that network is and the wider the web is, and the more people can support each other from the outside in. So the most centric people get to take care of the person who's dying, and then the people behind them take care of them, and so on. And I think that that's also really valuable. We also need to tell our medical providers. If you have a doctor that you share a lot of information with, your primary care physician, your nurse practitioner, your oncologist, somebody who's going to be part of whatever the care team is for you, they should know what your wishes are as well. And one of the most amazing things in this financial crazy world we live in that happened in 2016 is that Medicaid and Medicare decided that they were going to pay physicians to have the end of life care conversation with patients, not necessarily to initiate it. But if a patient says, I want to talk to you about this, the doctor or the doctor is going to be paid for the time they spend with you, and they get paid in 30-minute increments. It's not like the usual 15-minute head-to-toe assessment where they're supposed to tell you you're okay from year to year. This is 30 minutes, and they can keep getting reimbursed every time you have the conversation. Because Medicare and Medicaid covers it, that means that insurance companies who follow Medicare and Medicaid, which is most of them, will also pay for this conversation. So when you go to your physician, when you call them now and you do a telemed conversation, make sure that you remind them that you want to have this conversation if you're ready to do it. Some of them will tell you that they've never done this before. And so for those who are comfortable doing it, you can help them, prepare them for the conversation with other patients. It's a great gift that each of us can give. This one's easy for me. I have this conversation all the time about myself, about my husband. We talk about this. We've already buried 3 parents between us. We've had this conversation a lot. Um, but for people for whom this is uncomfortable, if somebody else can help prepare their physicians and their medical providers to have the conversation, the better off the whole world is. So if you want to plan some time with your care providers and also to let them bill a little bit, it's a good idea to have the conversation with them when you can. Your clergy. If you're in a religious institution, if you're part of a religious network of some sort, it's a good idea to have this conversation with your clergy. Hopefully they've been trained in talking with people about it, but if they haven't, you'll be part of their training. I think part of it is to expect that people are going to be maybe as nervous hearing it as we are talking about it. And so, so kind of offer the same kind of um, what's the word, patience, and give them the space to listen as much as you want to talk about it. Um, it's not your job to take care of us clergy, and it's not your job to take care of your medical providers. Um, but it is a way to make sure that they're able to help you as best they can if they're actually able to listen to you. And ask them the question, ask your family the question, ask your friends the question, do you want me to stop now? One of the things that we know about the way people take in heavy information is that sometimes we share too much too fast. And while it might be important in crisis time, when when we're doing advanced care planning, which means we're talking to people while we're still able to talk and we're healthier, um, we can say, I want to start this conversation with you. And when you get to a place where it's too much, let me know and I'll stop. And then when you're ready to hear more, let me know. And it may be days and it may be weeks. It might be a little later. I'll call you in an hour. Maybe I'll check in on you. And you can always tell me it's not time. But it is something that we should open at some point and then kind of keep up with it until we've move through it. Sometimes it's a good idea to share this, like if you have, like we do today, where we have a bunch of kind of Brady Bunch style Zoom links opened around a center eyeball here. Or I don't know, you're probably seeing me in the center. But the idea would be that if you share, the people who are comfortable sharing, if they share it in front of the people you know aren't comfortable sharing, it might open them up. There's a great Diane Sawyer Nightline episode where she interviewed a family that was having the conversation, and it was about the grandparents. And while they were talking, one of their 18-year-old grandchildren who was sitting there told the family what he wanted for himself. And I think that's really an important piece of this. When we open the conversation with the people kind of as as a theater in a way, like we do it with each other, with other people watching, an audience, it may open up the opportunity for them to do as well. I want to talk a little bit about COVID-19 and why we're doing this now online. One of the things is that with cancer and sometimes with heart disease and diabetes, we have decades to have the conversation. We go to our physician, we start getting tested for things, we start getting results, we get sent to specialists, more specialists, then treatments are started. Sometimes they work, sometimes they don't. And eventually we get to a place where the process isn't working anymore for life sustaining and we have to make new choices. With COVID-19, one of the things that's clear is this process is dwarfed into a very short span of time. And so hopefully after this opening this evening, people will feel more comfortable having this conversation and will maybe save themselves and their family members and their friends from having to think about this while they're dealing with an emergency crisis in the moment. Also, it's a little odd because we're not in the same room sharing with each other. We're in Zoom rooms, sharing the information with each other and sharing the conversation, and it's a little awkward. I'm the kind of person, I'm very gregarious and I'm outgoing, and so I love direct interaction. I love seeing people's eyeballs and stopping and saying, hey, wait a minute, you look like you have a question even though you're not raising your hand. Or this, if this is making you uncomfortable because I notice you're sitting back a little bit and kind of arms are crossed or whatever that might be. I like the opportunity to be able to engage. And here I'm gonna kind of spill all this stuff now and then we'll open it for conversation, but it's still gonna be stilted because we can't all talk at once. The other thing right now, why COVID-19 is causing us to want to have this conversation right now, and why I'm willing to go into this weird technical space to do this. And that is that we are not allowed to go to the hospital with the people we love who are dying if they die there. And if and to know that we've shared with our families what our wishes are and that they've shared with us, so that that conversation we know is complete on some level before somebody's rushed to the hospital, is a different kind of leaving than it is if they're being taken away and everyone turns to each other and says, I wish we knew what they would want them to do when they get there. And that is, and I wish I could be there to hold their hand while we're going through this. And I wish I could be there to speak for them. Sometimes at the hospital, they can pick up the phone, a local nurse close to the bedside can hold a conversation, can hear your wishes from the family members and from friends. And sometimes they're so busy that that conversation won't even be held, no matter how much you want to talk to them. So doing this early is a good way of making sure it happens, and hopefully it won't be necessary, not now. We do know another thing we say in hospice is that death is 100%. We know statistically we're all going to die. And so whether we have the conversation when we're young and healthy, or older and healthy, or we're somewhat healthy or unhealthy, but we still have a lot of time, we know it's coming. So having the conversation now, magical thinking, very communicable virus, heavy duty diseases, comorbidities that we carry with us, whatever those are, it is important, I think, to have the conversation while we're able to have it, so that we can free ourselves and each other up to really get the most healthcare we can in the moments when we need it, and to support each other the best we can. I want to talk a little bit about, actually, I think what I'd like to do is open it up for conversation now a bit, open up the chat. If you want to, probably you could just unmic yourself, or you could raise your hand. There are a bunch of us online, but probably enough that I can kind of single someone out. Does anybody have a question or a comment? Something you want to say? You're now all unmuted, so you can talk if you want to. And you don't have to. I have more to talk about.
I'll say thank you for having this conversation. You know, I really appreciate it. This is one I wish I had had last summer. And I have my mom passed away this summer, and we, for more or less, she had dementia for several years, and so we were making decisions for her for a long time. But it's a conversation that the rest of my family won't have. I'm very comfortable talking about death. I'm very at peace with my own death, and I think that that is something that could be contributed to the conversation, because I think the more at peace you are, the easier that you're going to be a cool, confident leader in that conversation with your family. You know, I am enjoying everything you said. I had my daughter join us for the first part, and I'm glad she got to hear it from somebody besides me.
How old is she?
Huh?
How old is she?
She's 14.
Oh, wonderful.
Yeah. And she chose not to be in the video chat, but she,
That's okay.
but I'm interested to know about the forms and the paperwork, just because, like, personally, I wrote a will in a Google Doc and shared it with my, like, 2 family members, my dad, my cousin, and my best friend. And I don't know if that's good enough. I don't know if I need to sign something. I don't really have stuff to distribute. I'm just trying to do the right thing.
Sure.
And the other 2 forms, you know, do you have those on hand
Are
regardless?
you in Texas, by the way?
I am, yes.
Okay, good. I'm gonna, do you mind if I take over again?
Mhm.
Okay. Were there any last things you wanted to say before I?
Oh.
Okay. So what I wanted, if you'll mute yourself again, I think we'll get back there. It'll come back to the center. So I do have the Texas documents online, and we will email them to anybody who wants them afterward. I'm going to put some of them up in my, I'm going to share my screen a little bit so everyone can see them. For those people who are not in Texas, these documents are all state-bound. They're all free. You can get them from your Health and Human Service Department in your state. You can just Google whatever the document is and make sure you're getting it from a state agency and not from some law practice that's going to charge you to fill out the documents. All of these are free, and you don't need a lawyer to fill them out. The one, Tiffany, that you were talking about, however, is not one that we're talking about tonight. That's your last will and testament. That's about your property and your and the paintings behind you and your couch. And so those documents you probably should work them over with an attorney just to make sure that everything is clear. The will that I'm talking about, the living will, is about your end of life choices, and that's all it's about. Medical power of attorney only makes decisions about medical issues when you can't speak for yourself, and does not have any power about selling your real estate or giving away the piano. This is all, this person's job is just to speak to your medical providers and say, please do this, please do not do this. And that's their job. And the last document is the out-of-hospital DNR. And I'm just going to show you what they look like in a moment. First, I want to tell you something about all three of them. What makes these documents legal is the form that they're on, and that each of them has 2 witnesses that you get to sign them. Now, here's the problem. If you're trapped at home with people you're related to, one of the witnesses, witness number 1, cannot be related to you by blood or marriage or by will. So if you're leaving them something, they can't be in your other will, they can't be your primary signature witness on these documents. They can be the secondary witness, but it's better to get 2 people that are uninvolved in your life that way. What that means in this world that we have today is maybe putting the documents in an envelope on your front step and waiting inside while a neighbor comes and signs them, witnesses them, with you able to talk to them. And then they put them back in the envelope and you take them back in your house, so that you're not sharing the virus, but you can make sure the documents are signed, and make sure you put a pen out there as well. When you bring them back into the house, we do know that the virus, or we think that the virus lives on paper for a short period of time. So just take the documents and leave them somewhere for a while, maybe a couple of days, and then you can touch them again. And also make sure you and the person who signed them, washes their hands before they touch their face or do anything else when they get back to their home. It's this is going to be important, I think. You can. I don't want to give permission to anybody to do something like sending them digitally, having somebody sign them and send them back, because I don't know if digital signatures in your state will count. I don't know, in fact, in Texas, if they're going to count. A secondary document can be a photocopy, but you always need the primary one with real signatures on it. So some way we're going to have to figure that out. And hopefully this won't happen, but if this virus infects enough people and causes enough death in the medical world as well as in the general world, we may have to come to a point where you're not going to need witnesses for these documents, where just stating what it is you want is all we're going to have. And so for right now, I want to keep everything to be at its legal best, hoping that all of us make it through and that we don't need to use these until the future sometime far off. But I want people to know that to pay attention and to see if things change as the virus progresses through society. Hopefully within the next month, we're going to be on the other side of the most of the loss, and we'll be able to kind of reevaluate what we need to have happen after that. The out-of-hospital DNR form, I'm going to, let's see. I'm going to open that one up now. I'm going to share my screen. Let's see. So this is the Texas out-of-hospital DNR. You can all see that? Just shake your heads. Yeah. So this document is a legal document that has a lot of seriousness attached to it. So that's why there are a lot of black lines on it. They want you to know that this document has to be done in a particular way or it will not be honored. This is the form that people fill out when they don't want to be resuscitated outside of the hospital. And that includes in an ambulance, in the emergency room, and in the hospital in a hallway until they have been admitted to the admitted to the hospital. Until an admission happens at a hospital, not when you get there, but when you've actually been admitted to the hospital and they're going to keep you, that's when the in-hospital do not resuscitate order takes over. The out-of-hospital DNR carries you all the way to that moment. So if somebody gets to the hospital and their heart is still pumping and it stops in the emergency room, this is the document that keeps them from trying to resuscitate that person. When this document also lasts so that if you go to the hospital and you don't need it, and you get out of the hospital and you survive, this document still stands. So if something happens later at home, an EMS shows up and somebody shows them this document and it's filled out correctly, EMS will not do CPR. The other thing here, this document is the only one of the three that requires a physician's signature. So you need 2 witnesses or a notary public, not a notary and witnesses, because the witnesses stand for themselves. The notary is there if you don't have witnesses. But the 2 witnesses or a notary public, and you have to have a physician sign this. And the reason that is because this is a medical order to the emergency medical service department. And this tells EMS that a doctor said don't do it. If you don't have this filled out correctly, EMS will do CPR. They will try to start the heart. And there are places like where my mouse is for signature witness 1 and witness 2 and their printed names and the date. Down here, look, it says witness 1 and witness 2. This line says all persons who have signed above must sign below, acknowledging that this document has been properly completed. They have to sign it twice. So does the physician. This space in here is where you get 2 physicians to sign it instead of witnesses. And that's if the person who is making the out-of-hospital DNR can't speak for themselves, or they're not able to communicate. Maybe they have some mental disability and they're not capable of saying what they want. 2 doctors can make the decision for them. So that's the out-of-hospital DNR. If normally in normal society, you know who has these? People who are on hospice care at home, or people who have been to the hospital 15 times with broken ribs because their heart has been started over and over, and they're getting weaker and weaker, and they're older and frail, and they just want to go the next time it happens. They want to be able to die. They would have one of these. Normal, healthy, young people, older people do not have an out-of-hospital DNR. However, in this time, if somebody were to get very sick at home, which can happen very quickly with the virus, this may be an appropriate document to have. But that's a decision for you to make and to make with the people you love. This document has a front and a back, and the back doesn't have any places for signatures. But if you duplicate this and you print it on 2 pieces of paper instead of front to back, they have to be attached to each other. You can't just have the front and make this valid. It needs the back page because that's the instruction page, and EMS is going to want to know that you knew what you were doing when you filled it out. So just be careful about doing that. And remember, do not resuscitate is only about starting a stopped heart. This is not about helping you breathe. This is not about putting you on a ventilator. If your heart is pumping and you're not breathing well, and you don't want them to put you on a ventilator, that's a different question. This one's about don't start the heart again, just so you know. Okay, I'm going to switch documents. I'm going to go to the medical power of attorney. So these are the codes that make this a legal document in Texas. And I want you to be sure that whatever state you're in, you're using the documents that are valid in your state. And again, you don't need a lawyer for these. They're easy to fill out. They just need signatures usually. This one says, and I would say Lev Baesh, appoint, and then the name and the address and the phone number here would be the person that I appoint to make medical decisions for me if I can't speak for myself in a medical emergency. What does that mean? If I am unconscious and they try to kind of wake me up and they try to say, squeeze my hand or blink my eyes, and I can't do any of that, my medical power can step in. If I can blink my eyes in a way that says yes or no, and they can make that decision, I still get to decide what they're doing. If I'm unconscious and my medical decision maker, my medical power is making decisions for me, and I wake up, it's my power again. So you only give it over when you give it up, when you can no longer speak for yourself in the moment. And if you regain that power, you gain the power of being your own medical power of attorney. Sometimes people will put limitations on the decision-making authority of the agent, of the legal power of attorney, and the medical power, sorry, not the legal power, the medical power of attorney. Limitations like, if this has to do with my cancer diagnosis, I want them to make the decision. But if it has to do with something else, I don't want them to make the decision. Or if they're deciding about intubating, meaning having a tube down my throat to breathe for me, I want them to make the decision. But if it's about feeding me or not feeding me, I don't want them to make that decision. I want the medical team to make it. The one thing that I'm going to suggest, and I always suggest this, doesn't matter what the situation is, the less limitations you put on your power of attorney, the less limitations you put on your medical deciders to decide in the moment what is the best care for you, the less time it's going to take for them to treat you. So just to be clear, you have the right to make all of the limitations you want. You just want to make sure that you don't limit them so much that they have to kind of stand back and say, I don't know what to do now, because what they need and what the limits are close, but they don't match. And so it's a hard thing to decide. And for example, if somebody says, I don't want them to decide if I need, I'd want my doctors to decide if I need to be artificially fed. So does that mean fed by another human being, or does that mean fed by a tube? Like, if we don't state our limitations based on what we need, it's going to complicate things. So that's one thing. Another thing here is it gives you a space for a first alternate and a second alternate. When you're choosing a medical power of attorney, you should always choose more than one person. Let them know who's primary and who's secondary and who's tertiary, but don't just have one person, because what if their phone isn't working? Or they happen to go for a walk with their dog and they left their phone at home. We want people to be able to make the decisions quickly. We want physicians to be able to pick up the phone and call someone and get an answer immediately. We also know that sometimes the person we chose they get sick themselves. And so we may need other people to make the decision in the moment. Let them know who's primary, secondary, and tertiary, so that the ones you want making the decision first are the ones who make the decisions first, and not that it comes in that they have to fight with each other over it. Also, I'm not sure I understand. Oops, Siri was getting involved. Also, to know that not only do you tell the people who are going to be your medical power of attorney, but you need to tell the people who are not going to be the medical power of attorney. If your parents or your spouse or your partner or your child thinks they're in charge and they're not, they need to know that. And all the people who are medical power need to know who's not in charge, and they need to have a conversation with you together, probably, so that it's square about who's making these decisions. One of the things that we do when we choose a medical power sometimes is we make sure that we pick somebody who's strong. We make sure that we pick somebody who can do what it is that we want them to do, and not to fall apart or to get jumbled up or to make decisions that we wouldn't want to make for ourselves. If you believe fully that the medical team should try everything they can to sustain your life, and your medical power of attorney doesn't believe that's appropriate, they're going to be speaking for you. So just make sure that you're on the same page. Some people, rather than choosing to say, I want all sustaining care or I want all comfort care, what they say to their medical power of attorney is, I've chosen you because I want you to be in communication with the medical team, and whatever you decide with them in the moment, that's the decision I would make, and that's what I want you to do. So you don't have to kind of bind their hands and say, do what I want now. You can say, do what I want in the moment, because you know me and you know what's going on medically, and I won't know at that moment. I won't be able to know what they're doing or not doing. Also, choosing a medical power of attorney who isn't the person who's closest to you may be a good choice if it frees up the people around you to love you and to care for you and to mourn for you, and not to be making decisions in that moment. I know that as a nurse and as a rabbi and just the person that I am, when I had to make decisions for my parents, and when my husband, who's also a nurse, made decisions for his parents, we were both able to grieve and deal with the issues at hand in the moment. I'm not sure I would have wanted my siblings or other people to be in that spot. I felt like I could take care of them in that moment, and I would take care of myself later. But maybe, and we also both implored friends who are a minister friend of ours and her husband to be there if we're not able to speak for ourselves, because we also know that they know what we want. We all have similar beliefs about end of life, and we also are strong decision makers and can stand up for the rights of each other when if we were in trouble. So that's important. And then here on this form, it says if there's a duration, and that's just, I want this to stand until the COVID virus is taken care of, or I want this to stand until only if if I end up in the hospital. If I'm at home, I want other people to make the decision. So there's a duration piece on here as well. And I think that's it. This one has a place for a notary public or for two witnesses. And again, primary witness, not related to you by blood, marriage, or will. And that means your last will and testament. Don't leave them anything if you want them to be your primary, because you don't want somebody to be questioned about why they're deciding to not sustain your life if they're going to be inheriting everything that you own. So don't set them up for failure in that moment. So that's that form. And then I'm going to show you the last one, the living will. And then I'm just going to open this up for more conversation. So the living will is also called the directive to physicians and family and surrogates. Remember, you need to get the ones that are state appropriate for where you live. And this just says, I recognize that in order to be in healthcare partnership with my physician, that these are the things that I would like to have happen. And this first one is, if I'm suffering from a terminal condition, that means I'm going to die soon. Either check here, I request that all treatments needed to make me comfortable be other than those that need to make me comfortable be discontinued. And my physician allow me to die as gently as possible. Or check this one, which says, I request that I be kept alive in this terminal condition using all available life-sustaining treatment. Those are the two options. The second one says, if I'm suffering from an irreversible condition, and that's the one where I'm not going to die today, but I'm going to end up in a nursing home, unconscious and on life support, and I might last another 10 years, but I'm not going to have the life that I've wanted and that I expected. And here are the same two choices. I request all other treatments except those needed to keep me comfortable be discontinued, or I request to be kept alive in this irreversible condition using all life-sustaining treatment. It's important that both of those decisions are made. Here's a place for additional requests. And again, and it's really nice that it says after discussion with your physician. It doesn't have to be, nobody's going to ask you whether that actually happened. But the idea is that you should know the most about your condition and what kind of life you're going to have if they continue to sustain it, or they continue to sustain it over a long period of time, or what kind of life you're going to have if they stop life-sustaining treatment and they're only doing, or not only, but they're doing comfort care. In both of those cases, what is my life going to look like? Because am I going to be in pain? Am I going to be left alone? Am I going to know what's happening to me? What if my condition changes? What are the possible changes? If you want to put conditions on this, you should know as much as you can about what life is going to look like in that state, so that you can make informed decisions about what you want to, what additional requests you want to make. Again, my suggestion, but this is only from me and not for you. You get to decide this for yourself. The easier these forms are filled out, the easier it is for your physicians to treat you quickly. And the easier it is for family members to move into the caretaking, loving, and then mourning process if and when that comes. All of these forms are, and again, this one is, if you don't make a medical power, you need to let them know that. You can let them know that, or you can give them the medical power form. This is a great document to give your medical power of attorney to keep with their other document, so that people know that they're making the decision that you wanted them to make. Especially if the decision you're making is different from the one the people who love you are going to fight you about. Again, witness 1 and witness 2, and then just some other information at the bottom. So those are the 3 forms. We're also going to make available to you 2 packets. One is a conversation starter kit, and this one's great. It's written like the most simple medical survey. As a patient, I'd like to know only the basics about my condition, or tell me everything. Right? And this is the kind of information, when you're having a conversation with the people who love you or care about you, they're going to want to know. Like, do you want us to talk to your doctors and bring it to you, or do you want the doctor to stand over your bed and tell you what you need, or the nurse practitioner? Or do you want certain people out of the room while we're telling you what's happening to you, or do you want everybody present? These are the kinds of conversations to have with the people you love long before there's a problem, and that way they can all kind of maneuver themselves in appropriate ways as best they can if there's a crisis. Are you concerned that you won't get enough care, or are you concerned that your care will be overly aggressive? Those are questions people want to know, that are helpful to know. When the time comes, I want to be alone, or 5. When the time comes, I want to be surrounded by my loved ones. And I'm telling, even even if we go to the hospital alone and nobody's able to be there, if somebody can tell the nurse or the doctor or the nurse practitioner who's present with us when we're there to please pick up the phone and dial everyone in, that before they turn something off, that may be important. And I think it's important for everybody to talk about that as early and as safely as we can. And some questions in here are about the conversation itself. Where do you feel comfortable talking? Like for me, I'm sitting at the kitchen table doing this talk. Some people are better in the living room. I would advise not having the conversation while you're driving, although it is possible that you could take a drive with the people you're allowed to be with and maybe take a walk in the country um, and have the conversation out in nature. It doesn't have to be indoors. It just has to be away from people we're not allowed to congregate with right now. Here are some icebreakers. I love that we use the same term for talking about end-of-life care as we do when we're at summer camp. I was thinking about what happened to Joe, and it made me realize, and then continue the conversation. Or even though I'm okay right now, I'm worried that this is going to happen and I want to be prepared. And I need to think about the future. This is for me. And I would like you to help me. Can you help me think about this? So it's not always directing the information out, but it's enlisting other people. So this is booklet number 1, and then we're going to make that available. And then the other one is really a nice way to how to choose and how to be a healthcare proxy. If you want to pick somebody who's never done this before or is scared about it, this booklet is a great way to kind of warm them up to the opportunity to be a healthcare proxy. And then also we're going to make available 2 evaluations. We would love to get one of these back from you. One is for community members, and that means you're not a healthcare provider. And one is for healthcare providers. It's the same survey, but it helps us know who's using this information. And if you're a healthcare provider, you could be a doctor, a nurse practitioner, a nurse, a social worker. You could be a Reiki therapist. You could be a holistic a naturopath. Anybody who considers themselves in the medical world in some way, we'd like you to fill out that evaluation, and the other one from for members of the community. I'm going to stop sharing my screen. There we go. We're all back together again. And just let's open up conversation again, and we can go anywhere. We can go anywhere with this.
Hi, Lev.
Hey there.
Thank you for doing this.
Oh, you're welcome. It's good to have you here, Martha.
It's nice to see you in person.
In the flat flesh.
In the 2D flash.
Yeah.
I have a question about what happens if these things haven't been talked about or decided. Is there a default that the hospital goes to and uses?
Yeah. Yes. So in the medical world, currently,
Mm-hmm.
if they need to choose between life-sustaining and comfort care, they will always choose life-sustaining. They do not want to get sued. So so if you don't have this information in their hands when somebody arrives at the hospital, they do have to make that particular choice. We understand right now that we're hearing it, and at least in the news, and Governor Cuomo is talking about it. The mayor is talking about we may get to a point where they have to make different decisions because of the amount of equipment that we have available or not available. And so we want to have these conversations no matter what happens in the medical world. I think the idea is preparing ourselves and our family for that event. It may come down to the fact that they have to choose not to provide life-sustaining care because they think it's not going to sustain us and somebody else might benefit from it, and they only have one machine.
Right.
And so that decision is going to have to be made at that time, and they're going to have to deal with the repercussions of that when we come to the other side of this. But for right now, we're still in a world where if you ask for it or you don't ask for it, they're going to have to give it to you, full care. And especially if you're not somebody who's 99 years old, and I mean, even then they'll do it, but if you're 30 years old, they're not gonna let you get comfortable and die if you haven't told them that's what you want, and they still have the equipment to do what they need to do, and the staff power. Because we're also losing nurses now too, so we're sort of all hands on deck everywhere. Anything else?
Well, so then is it recommended that you have these things handy at all times?
Yeah. Mm-hmm. Yeah, I think at least that people should know where they are.
Mm-hmm.
If you're home, because we're all home now.
Right.
If you're going to the hospital, it's because the ambulance is coming to get you.
Mm-hmm.
So hopefully you're not there alone. And if you are, then you have the documents on the table next to you, or on your belly. What we also do is you can download them to your phone. There are apps for iPhones and for Androids that are free, and they're document forms for this medical world, and they live above your password. So like a 911 app, so that if somebody opens your phone, they can get to those documents, even if but they won't be able to get to anything else, so that they can see that you have an out-of-hospital DNR and you have these other things. Trust me that most likely they're going to do what they can first. They're not going to look for stuff. But if somebody doesn't know you have these documents, but they have your phone, like somebody you live with, they might open your phone and you could just say everything's right there.
Yeah.
So you can show them. And it also makes, so that's important. Oh, go ahead.
Well, my family had an experience of out of the hospital DNR in place, but when the time came, it was not close enough at hand. And yeah.
In nursing homes, when patients are no longer mobile, the out of hospital DNR goes above the bed, like taped to the wall.
Yeah.
If you're in a place, if somebody's in bed, if somebody's starting to feel that sick and they can't get to the front door, it's a good idea before that moment, like when people are still healthy enough to move around, to tape it to the inside wall, that is when the door is opened, that it gets seen first.
Mm-hmm.
It's just, there are ways to do this, or to keep it next to you in the bed or on the couch.
Because I imagine in this landscape that, like, my wife wouldn't be able to get to the hospital to hand mine in.
Right, but she would be able to give it to EMS when they come to get you.
Yeah, but if it's not on hand, then it's going to be hard to get it there.
That's right. It's also a good idea. We do this all the time, and that is when we're not in this situation, but to go to the hospital and to register where you live, and give them all that information ahead of time, so so that they have it. But now I'm not sure we're able to do it by calling it in, because they wouldn't know who's on the other end of the phone. So unless your physician has a direct access to the hospital, like they share medical records, then you could give them to your physician through their safe document downloads, and they could pass it off to the facility.
Okay.
Yeah, it's good. Those are good questions. Yeah. Anything else? Anybody else?
So it looks like Nicole asked a question that says, can a friend who is an MD be your medical POA, or is it considered a conflict of some sort?
Can a friend who is a physician? No, it's not a conflict as long as they're not your acting physician in that moment. Yeah. So, because a lot of us are in the medical world, and we share that with people we work with, and So no, not in that case. The only issue is don't pick somebody who's going to be treating you. You wouldn't want the ER doc at the hospital to be your medical power of attorney. That would be a conflict. Anybody else have any questions, either typed in or?
Lev, I had a question come in. Where's
Sure.
organ donation in the documentation and conversation?
Say that again?
Where is organ donation in the documentation or conversation?
Yeah, so organ donation should be on your driver's license, and also registered with, so your medical power should know that as well. My guess is with COVID-19, there is not going to be a lot of organ donation going on, because you'll be passing organs that are infected. So I think in this moment we're probably not going to see a lot of that happening, if at all. But if somebody goes to the hospital for, let's say, a heart attack and their heart is still beating, they're healthy, and they don't test positive for COVID, you would want the medical world to know what your stance is. So if you don't have it on your driver's license and your driver's license isn't with you, your medical power should know that you want that to happen. And by the way, there's a default order to medical power if you don't have a document. And it starts with spouse, and it goes to parents, and it goes to adult children, and there is an order to it. Even if those people are around and they would be your medical power, it's a good idea to put it in document form, just to have it as a backup in case somebody flips out.
Can you tell us a little bit about the rest of the series and kind of how you're guiding us down it's 4 conversations, right?
Yeah, so I'm only doing this one.
Okay.
There are different speakers with different topics, and I don't know what those are at this point. A lot of, since COVID is moving quickly, and the landscape is changing, the organization is building what people need as it comes up and as people are asking for stuff. Is there anything in particular that you would want to have a conversation about or hear about?
I don't know. You don't know what questions to ask, like you said in the beginning, until it's kind of too late. Like it's, and so for me, it seems pretty straightforward. There's some documents that you need to have on hand. They need to be accessible by your people. Your loved ones need to have a grip on where they stand in the grand scheme of your preferred death plan.
Yeah.
I think the only thing, I just don't know what I'm not asking or not thinking about. I wonder about people that want to be cremated versus buried. You talked a little bit about spiritual beliefs, and there were some things that I just I didn't know, I didn't even know. So are those things outlined somewhere, or is there like a guideline for?
No, it's a really good point. It's something actually after we talk, I'm gonna just start to jot some notes and maybe send them over to Sarah and the gang and see what they can come up with. One of again, medical power really is making the decision about medical treatment in the moment. It's a good idea for them to know things like organ donation is an after the fact choice, because you're no longer, there's no longer a choice about life-sustaining treatment or not. But it is something that they can decide, they can tell people that you want. And if you have it documented in some way with them or with somebody else, then you can follow through with that. And the same is true for I don't want organ donation. We in the hospice world and in the medical world that I've been a part of, we don't try to make decisions for people, and we don't want to move people in a particular direction. We know what's helpful, what we've seen that's helpful, but we want people to decide what matters to them. Oh yeah, here's something I want to bring up. Thanks, this was great. We want people to decide what's important for them and make it possible for as best we can for that to happen. That's the goal. Okay, so with that said, Here's one of the things I want people to think about at end of life, because one of the reasons people don't want to have this conversation is it's all about tubes and IVs and needles, and it's about medications, and it's about nursing homes and hospital beds. That is the mechanical stuff about end of life. What we haven't talked about, or what I haven't talked about yet, is about values and about what you care about and what's important. And now the nurse, who's also a rabbi, is going to come up a little bit, and that is what we like people to think about when it's preparing for the end of life, when we're healthy and strong and we're able to think about it, is about the resources that we use at the end of life, and to think about how we want those distributed to ourselves and to others. So if you're the kind of person who has spent your life believing that everybody should get everything they can in life, then at the end of life, your decisions about what you take in, what medical equipment, what treatment, how many people are working on your body, how much bed space you take up, that would fit in line with that view, that everybody should get everything they can. If you are someone who believes that there are limited resources and that there is a need to share that across the board, and that if my life is going to be such that I'm not contributing in the world the way I'd want to after this procedure, and other people might benefit from the equipment and the people and the medications and whatever else I'm going to be using, I'd rather it go to them than to me. And this is not about being selfish, and it's not about being grandiose or a bleeding heart. It's about really following through with your values and the way you live your life all the way to the end, so that what your life means now and it did before can mean that at the end. And also, it might be a wake-up call for somebody who sees themselves as selfish and wants to be different than that. We can make different end-of-life choices to not use up all the resources on ourselves, to spread them around. Or for somebody who's denied themselves their whole life. One of the things that was really interesting in our hospice talks in Austin, we went to an African-American church, and one of the statements that somebody made was, they believed strongly in sharing resources, but they also understood that for themselves, their own experience has been, if I tell the doctors at the hospital to do less, I'm going to get less than less. If I tell them to do everything, I'm going to get some, but I'm not going to get all, because of the color of my skin, or because of my financial status, or because the way my mouth looks, my teeth, or because of my gender. And so they raised the point that they walk into the hospital already prepared to not get the most care, so they're going to ask for everything. And I think it's important for us to, and this was not across the board there, but it was voiced. And I think we need to really respect that. We need to understand that statistically, women don't get treated as well as men when they go to the emergency room. That women don't get taken seriously the way men get taken seriously when they ask for stuff or they say things in the emergency room or in the hospital. Statistically, that's what happens. And it doesn't matter if the medical team is male or female or across the spectrum. This is one of the current statistics that we're working to change. And so, and with all of the gender fluidity now, just as there is with religious fluidity, and just as there is with ethnic fluidity, people don't walk in looking or sounding or experiencing the world the same as everybody else. And the medical world doesn't know how to relate to that really well yet. And so, so I think we want to be as prepared as we can be so that we can help them take care of us, and that we can help them take care of other people because we've prepared them with taking care of us. So we can do all of that in that moment when we decide I want all life-sustaining equipment and work, or I want all comfort care. And that's that's the last voice we get to give to our values in the world. And I think it's an important thing to consider. It's also another icebreaker when having the conversation with other people, and especially now when we listen to the news and we hear about limited masks and gloves and respirators, and we say, if there was one left, if you're on a lifeboat and it's you and somebody else, what do you want to have happen? And and I think that's where the conversation can be a game, and it can be easier because it's more playful than just, if you're going to die, do you want them to turn off the machines right away, or do you want them to wait? Like, I think there are ways of going about, that's the way I would have the conversation. But for people who are not as what's the just smart alecky as I am, I think that there is really there is the opportunity to kind of think of more comfortable, casual, engaging ways of having this conversation where you don't have to get to documentation. And truthfully, the documentation is worth nothing if you haven't had the conversations. And if you've had the conversations, the documentation is really almost irrelevant. It's nice to have it because it proves something if there's a problem. But it's also really beautiful, I think, to have people who can speak for you, and people who know what you want, and people who can support you, and that you can get what it is you want and you need because you've set it up that way. And I think that's really the kind of the heart and soul of this conversation. And we will give you the documents anyway. Anybody else? I did, and I'll let you interrupt me at any point. I did want to tell you a little story. My father and I had this conversation before he was going in for surgery. It was 3 years ago, and I asked him at the time if I could share it because I didn't want to break his confidence, and I didn't want to do anything against HIPAA, the rules of caretakers, and even though I'm not his caretaker that way, but I wanted to honor him by not sharing stuff unless he said it was okay. And he's a smart aleck like I am, and he said, you can tell them whatever you want. So so my dad had never talked about end of life, and he was pretty ill at the time and going in for an emergency surgery that could have ended his life. I had no idea what he wanted at end of life. We hadn't talked for about 30 years, came back into my life late. And we're all happy about it, having him back. But so we're in the hospital, and I said, what do you want? He goes, well, I don't know. What am I supposed to pick? And I said, well, do you want them, if something happens on the operating table, do you want them to try to revive you, or do you want to let you go? And he was like, well, I guess I'd want them to revive me if I end up, being okay. And I'm like, well, what if you're not okay? What does that mean? And so we were having this conversation in the hospital. It was a beautiful conversation. It was very funny. We did it well. But we were doing it just as they were wheeling him out of there on their way to the operating room. And I was lucky. He was awake and alive, and I could have time with him, and I could walk down the hallway, and we could tell the nurse who was wheeling him what he wanted. But that was a pretty rare situation for people. And also there were no other family members around to say, no, Dad, don't do that. Don't change your mind. Don't, we don't want that to happen. Or what if this happens? And they start to scare him. We want to, he was lucky, and I was lucky, and he survived it, and he's still around now. And so, so there's that. And I've also been in the room as a nurse and as a hospice nurse where it is just brutal. The patient is scared, and the procedure is scary, and the family members are fighting over their head, and they're not talking to the physician, and they're not talking to me, and they're not talking to the patient, and they're just arguing about everything. And I get it. It's about care and love and fear and anxiety and lost expectations and who wants to be in control, and all of that stuff comes up around the bedside. And so sometimes we move people out into the hallway to talk with them. Sometimes we go to the patient and say, who do you want me to bring back in? I'll be the bad guy. You tell me and I'll say, we can only take one at a time, whatever we need. But in the world we live in today, it's so much more important to get all of that stuff the best way we can out into the world ahead of time, so that if people can be bedside, they can be there with us and hold our hands. And if people can't be bedside, when they're on the phone or on the computer screen, we can be with them in that moment too. Anything else? So I want to say thank you. We've been here together now for an hour and a half. It's been really, thank you for the opportunity to share. Thank you for listening, for sticking with this. Thank you for being interested at all. And if you want to talk with me, I'm stuck at home. So feel free. You can. I think, I don't know if my contact has been given out, but feel free to, from Waking Giants to give out my contact information, my email address, and I'll be happy to set up a time to chat with people if that might be helpful. And I'm also willing to meet with you and other people in your family if that's helpful too, or your friends. We could do another kind of Zoom meeting. I won't get paid for it. I don't want to be your rabbi or your lawyer or your nurse, but I can be a facilitator, and I can try to help any way that I can. So thank you. Have a wonderful evening. I hope everybody is healthy, is observing the rules, and hopefully, if your town doesn't have any rules, that you make the rules. And I'll look forward to seeing y'all. Just in my world, in the Jewish world, on tomorrow night we're doing another Sabbath piece with Waking Giants at 6:30. It's just a half-hour reflection on the Sabbath, and whether you're Jewish or not, you're welcome to attend. And then on the second night of Passover on April 9th at 6 o'clock, I'm going to do a kind of a reflection on the story of Passover, and people can eat while I'm talking, or we can talk, or you can go and have your meal afterward. But it's a way, I'm hoping that I can help set up the Passover story in the era of COVID-19 to be able to make that story come alive and be strengthening, and to help people get through this time in the wilderness. So thanks.
Thank you.
Thank you.
Thanks. Bye-bye.
Bye, guys.
Again, if you would like these documents that were shared in this session, please feel free to drop them in the chat box or chat myself or Rabbi directly. I also will drop in a link in the chat box in which you can see Dr. Sorry, I keep wanting to call you doctor. I don't know why. It's probably because you're like doctor and all the doctorates. Rabbi Baish's other events and speakers, I'm going to drop those events in the chat box. Again, thank you so much, Rabbi Baish. I can't explain to you how truly, truly integral this is in just talking about life. I just don't think we should be able to talk about birth if we're not going to talk about death. So I really appreciate all that you're doing.
All right. You too. Thanks for setting it up. Bye-bye.